Rhinitis is not a trivial, harmless, or unmanageable condition. Primary care clinicians can support people suffering from rhinitis by helping them understand that attention to triggers, symptoms, and effective treatment can significantly reduce discomfort and improve quality of life. Allergic rhinitis is strongly associated with an increased risk of developing asthma. Approximately 20 to 30% of people with allergic rhinitis also have asthma. Anybody with confirmed allergic rhinitis should be screened for asthma. People with allergic rhinitis are more likely to have frequent asthma exacerbations and have poorer symptom control than those with only asthma. Rhinitis is broadly classified into allergic, IgE-mediated, triggered by allergens such as pollen/dust mites, and non-allergic, not triggered by allergens. Examples include vasomotor, medication-induced, or infectious, respiratory viruses, and mixed phenotypes, that is, elements of non-allergic and allergic rhinitis. In the majority of cases, people with allergic rhinitis symptoms self-manage without seeing a clinician and stop treatment once they feel better, particularly in mild intermittent allergic rhinitis. However, it is important to identify those with uncontrolled rhinitis who require further care. When adults report 2 or more nasal symptoms indicating allergic rhinitis and self-care is not enough, management follows a treatment ladder based on symptom control as assessed by a visual analog scale. A visual analog scale is a simple but validated way to assess control by asking, how much are your nose and/or eye symptoms bothering you today, on a 0 to 10 scale, where 0 means not at all bothersome and 10 means extremely bothersome. A score of 5 or more suggests uncontrolled disease. Allergic rhinitis is also classified as intermittent when it occurs on fewer than 4 days per week or for fewer than 4 consecutive weeks, and as persistent when it exceeds both of these thresholds. The pharmacotherapy should be adapted to the severity and frequency of symptoms. As-needed therapy may be sufficient for patients with mild intermittent symptoms, including those with predictable allergen exposure, for example pets. Daily therapy is most effective for intermittent bouts that typically last about 2 weeks. Upon initial treatment, including non-pharmacological advice, in line with our desktop helper on rhinitis management, reassess after 14 to 21 days and discuss with the person or the caregiver whether the treatment plan needs to be adjusted. Step 1 starts with either an intranasal corticosteroid or an antihistamine, oral or intranasal. Intranasal corticosteroids are preferred, but patient preference should be considered. If after step 1 for 2 to 3 weeks, the visual analog scale is below 5, allergic rhinitis is considered controlled, and you may consider stepping down treatment, particularly with intermittent rhinitis. The average duration of a bout of intermittent allergic rhinitis is 2 weeks. If the visual analog scale remains 5 or higher, the rhinitis is uncontrolled, and you should move to step 2. In step 2, treatment is escalated to a fixed combination of intranasal corticosteroid plus intranasal antihistamine. Before stepping up, confirm the diagnosis, check adherence, nasal inhalation, and review other factors, for example, exposure to tobacco, alcohol, and chili in the diet. They may cause symptoms of non-allergic rhinitis, compounding the allergic rhinitis, but respond mainly to the removal of the triggers. If, despite correct use and adequate treatment adherence, the visual analog scale remains 5 or higher, symptoms are still uncontrolled, and you should progress to step 3. Step 3 is reserved for severe disease. At this step, review the treatment adherence, inhalation technique, and the diagnosis again, and consider referral to an allergy specialist. Treatment options include add-on therapies and, rarely, a short course of oral corticosteroids, used only very rarely and with caution, and consideration of allergen immunotherapy for suitable patients. Possible add-on therapies depend on the symptom profile. Review Figure 1 in our desktop helper on rhinitis management for more details of add-on therapies. Consider allergen immunotherapy, including sublingual immunotherapy for people with moderate to severe allergic rhinitis whose symptoms remain uncontrolled despite optimal pharmacological therapy. Severity is mild when sleep, work, school, and daily activities remain unaffected with no troublesome symptoms. If any of those facets are impaired, disturbed sleep, reduced productivity, or bothersome symptoms, the classification is moderate to severe. Use of the visual analog scale again helps quantify symptom burden, with a score of 5 or more indicating moderate to severe disease. Therefore, strong indications for allergen immunotherapy include symptoms that significantly impair daily functioning, sleep quality, school or work performance, or that persist even with low to moderate allergen exposure and are not controlled by pharmacotherapy. A confirmed diagnosis of IgE-mediated allergy is essential, based on clinical history and supported by positive skin prick testing or specific IgE to relevant allergens. Bear in mind local allergic rhinitis, which is a nasal allergy condition in which symptoms are present even though specific IgE tests and skin prick tests are negative. It should be treated primarily with nasal sprays, although oral antihistamines and allergen immunotherapy have also been shown to be effective. For non-allergic rhinitis, one of the key parts of treatment is avoiding identified triggers, which may include tobacco smoke, certain medications, or dietary components. Non-allergic rhinitis, especially due to viral infections, can be temporarily treated for a maximum of 5 continuous days with decongestant nasal sprays, phenylephrine, oxymetazoline, xylometazoline, nafazoline, but are not recommended for regular treatment of allergic rhinitis. Longer use greater than 5 days can cause rhinitis medicamentosa. Remember also the non-pharmacological treatment of allergic, non-allergic, and mixed rhinitis. 1. Saline irrigation. Nasal irrigation thins and removes mucus, clears proteins that induce inflammation, and flushes out irritants and bacteria from the nasal and sinus cavities. Nasal saline irrigation can be used for persons with all types of rhinitis and is a crucial component of treatment for individuals with chronic rhinosinusitis. 2. Other non-pharmacological approaches. Environmental measures for managing rhinitis symptoms primarily aim to reduce exposure to allergens and irritants. For instance, the use of car filters, sunglasses, air purifiers, masks, pollen screens, and monitoring pollen forecasts. Finally, monitoring and follow-up depend on the response. Full response suggests no need to review. Partial response suggests review of adherence, technique, and address any non-allergic factors such as smoking or occupational aspects. Non-response, especially when adherence and technique are good, suggests the need for diagnostic review and/or referral. Now, time to solve a short quiz to reinforce your learning. A set of selected IPCRG resources will be available for you at the end of this breath.